My name is Rob McCulley. I'm a staff cardiologist at the Mayo Clinic, and in the December edition of the Mayo Clinic Proceedings is an article that several colleagues and I wrote, and the title is "The Characteristics and Outcomes of Patients Who Achieve a High Workload, more than 10 METs, during exercise echocardiography." The first author was Noel Fine, who was one of our research fellows, who is now relocated to Calgary, Canada. The other authors were Dr. Patricia Pelliker, Dr. Mike Garashilo, and Mr. Chris Scott, our statistician. And what we did was we looked back at more than 7,000 patients who achieved a high workload at the time of their exercise echocardiogram. Our database consists of about 30,000 patients that underwent stress echocardiography during that 5-year period. What we found in this group of 7,000 patients who could exercise to a high workload was that for the most part, the exercise echocardiograms were normal. 18% of patients had some regional wall motion abnormalities, 12% had exercise-induced myocardial ischemia, and only 4% had evidence of extensive ischemia. We subsequently looked at their outcome, and with follow-up being on average 5 years, we found that for the most part, this group of patients had an excellent outcome. We looked at all-cause mortality and cardiovascular-related mortality. We also looked at the prognostic implications of information that was provided by the exercise ECG and the exercise echocardiogram, and found that when added to the clinical model, this information did not provide incremental prognostic value. When we looked at the outcome of subgroups in the study population, we were able to tease out a small group of patients who were at intermediate risk for death. The subgroup of patients that were at highest risk were those who had severe and extensive wall motion abnormalities at rest. In other words, evidence of a large prior myocardial infarct. This subgroup of patients were at intermediate risk with an annual mortality rate of approximately 2.5%. The cardiovascular mortality rate, however, was still less than 1% per year. The implications of the study are potentially important. For physicians who use treadmill exercise ECG without imaging, if they have patients who can exercise to a high workload, more than 10 METs, they should be in a good position to reassure those patients, even if those patients are diabetic, even if they have an intermediate to high pretest probability of having coronary artery disease, and even if they have a positive exercise ECG, or even if their patients do not achieve a heart rate of 85% of their age predicted maximum. Another implication of this study is that if you are assessing a patient in your office practice and trying to work out which stress test to order for your patient, if you can ascertain that they can do a good level of exercise, such as if your patient can climb a flight of stairs carrying 25 pounds, or cycle with moderate effort, or jog slowly for 5 minutes or more, or play singles tennis, these patients may be able to achieve a workload of 10 METs or greater at the time of symptom-limited exercise. In these patients, you may choose to do a confirmatory treadmill exercise test without imaging. The findings of our study have potentially important implications regarding the use of stress imaging in patients who can exercise to a high workload, and could lead to more effective use of healthcare resources. To conclude, patients who achieve a high workload at the time of exercise testing do not often have extensive abnormalities on echocardiography. And although the exercise echocardiographic findings do provide some prognostic information, it is not of incremental value in these patients who generally have a very favorable short and medium-term prognosis. Thank you for your attention.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.com. This video content is copyrighted by Mayo Foundation for Medical Education and Research.